Good evening, guys. Please just give me a thumbs up to let me know that the audio visual is working well, which means you can see me, you can hear me. You can see my pointer here on the board. Hello, Raj. I hope the audio visual is all okay. So please just give me a thumbs up, so that I know that I can proceed and you guys are all comfortable. Okay. Well, perhaps it's session number 2 today. We had a session yesterday on this INI-CET Premier League, focusing this exam that's just coming up. And the idea is that over these 2 sessions I cover up 20 topics from which I expect at least 60-70% of the paper to be there. So yesterday we talked of a little bit of fractures part and related areas. So today we are going to discuss things other than fractures, a bit of tumors as well. So with that intent in my mind, I'll just start with the discussion because you guys are in and the audio visual also seems to be okay. So good evening Kshitish, good evening DK, good to see you guys again here. So without wasting much of time, I'll begin because very little time is left before your exam. So there's a patient who's being evaluated by this doctor and he's performing some kind of a clinical test on this patient. Now looking at this image, you have to tell me the likely pathology for which this patient is being examined. So Pihu, DK, Kshitij, Rishi, Jitin. Yes. So please submit your choices. What do you think is the problem right in here in this picture? Well, for TA rupture, the clinical test that we perform is called Thompson's test. And that's a pretty different test. So this is certainly not TA rupture. The answer here is IT band. You are absolutely right. This is Ober's test. And you are examining for iliotibial band contracture. But can anyone help me out with the disease? Like, what would be the likely disease if someone turns up with iliotibial band contracture? Yes, Jitin, you are absolutely right. This is IT band contracture. It's Ober's test. This is just a repeat question from a previous analyst. Absolutely right. So this is likely a case of poliomyelitis. So guys, what happens in polio? Polio leads to an acute flaccid paralysis by damaging the anterior horn cells of the spinal cord. Now these paralyzed muscles eventually get replaced by fibrous tissue and they become fibrotic. Now this is what leads to contractures in polio. Okay. Now a very important contracture involves this iliotibial band. So what exactly is iliotibial band? Coming from the iliac crest, you have this gluteus maximus muscle from the back, and coming from the front is this muscle tensor fascia lata. So this TFL, tensor fascia lata, tenses this fascia lata in the thigh. So a strip of fascia lata becomes very tight and gets palpable as a band on the lateral side of the thigh, and that's what you guys know as the iliotibial band. Now in polio, paralysis involving these muscles, gluteus and this TFL, leads to contracture of these muscles, and this is what keeps this iliotibial band more taut than usual, causing this iliotibial band contracture. Now you can just imagine that this particular patient has this iliotibial band on the lateral side of the thigh that is contracted. Now in this position, this doctor will leave this foot and let this knee drop. In a normal person, when you want to release this hold, this knee will go and touch the other knee. But if this iliotibial band will be contracted, this knee will keep hanging in the air and won't be able to touch the opposite knee. So that is what Zober's test tells you about this iliotibial band contracture. This is one of the commonest contracture you find in the lower limb. Okay, so perhaps why contractures develop, you are clear. The commonest contracture we'll find will be with the iliotibial band, and this contracture in polio is tested by this classical test that is being performed over here, that's called as the Ober's test. So are you guys clear with that part? Understood well enough what is Ober's test? Understood the problem in polio, that first there will be paralysis of the muscles. The paralyzed muscles will be replaced by fibrous tissue leading to contractures, and paralysis in this TFL and gluteus maximus would tighten up the iliotibial band leading to its contracture, and this IT band contracted, that gets tested by Ober's test in polio. And when this Ober's test is positive, you need the iliotibial band release. You have to cut this tight band so that the patient can assume a normal gait pattern. Fair enough, fair enough, fair enough. Now please submit your guesses on this one. Although the history is too less here to conclude a diagnosis, but there's a 9 years old child who's come to you with this problem, a painless limp, and you've been asked the most expected etiology. So mind you, with this little history, very difficult to conclude, but certainly with this history there are some options. You'll keep them on priority basis. So what would be those options? That's what I wish to know. Yes. Okay. Fair enough, fair enough. So most of the people are in favor of Perthes disease. Perfect enough. Perhaps, if you talk of a painful limp. Now limp is painful in either of the two scenarios. One, there is infection or some kind of inflammation, or if there is trauma, some fracture, something like that, some physical injury. Now these would be the scenarios of infection, so you're going to get a painful limp. In transient synovitis and septic arthritis, so these options are out. So painless limp is possible in either of the two scenarios. So the answer had to be either out of the two. So most of you guys have chosen Perthes disease. But why Perthes disease? What prompted you that it's likely Perthes? Yes. So can I have that particular reason? Like what prompted you that this is more likely a case of Perthes? See, even in congenital dislocation of hip, you will have a painless limp. But what prompted you guys? Yes, Jitin, Bindu, DK, Kshitish, Navneet, Adnan. What prompted you guys that this is likely Perthes and not congenital dislocation of the hip? Age. Absolutely right. So please tell me the classical age where you find Perthes. Please tell me the classical age where you find Perthes. So Navneet, you're absolutely right. Bindu, you're absolutely right. Yes. 4 to 10 years. Absolutely right. So that's what's pointing it. That is more likely case for Perthes. In case you have no idea, I'll still brief to you what is Perthes. It's an idiopathic avascular necrosis that involves the femoral head, but as you have mentioned, it's classically taken to be this age group, 4 to 10 years. So that's the classical age group, 4 to 10 years, not adolescent. 4 to 10 years. Navneet, 4 to 8 years is again correct, but let me tell you, there have been few articles of late where Indian research has been carried out, and it has been observed that the age incidence in India is little longer. So they have refined the age group from 4 to 8 to 4 to 10 years. So keep this as the better age group, because in India this tends to present a little later than in the West. Clear? So 4 to 10 years will be the better answer. Now this age group is very classical. I'll tell you why. See, you all guys have an idea that what you have over here near the neck of femur is an artery called profunda femoris artery. This profunda femoris gives two branches that wind around the neck of femur. These branches are those circumflex arteries, medial circumflex femoral, lateral circumflex femoral. Now branches from the circumflex femoral go and supply the femoral head. So that's one way by which femoral head receives the blood supply. Now please, attached on the head of femur, there is a ligament that is called ligamentum teres. Running inside this ligamentum teres, you also have blood vessels that supply the femoral head, but these are basically part of the obturator system, the obturator artery. Now, in a very simple way, profunda femoris will be the dominant system generally after the age of 10 years, and obturator would be the dominant system generally under the age of 4 years. So you can very well see that this 4 to 10 years would be a watershed zone where one blood supply system is fading and the other one is penetrating. So as you cross 4 years of age, the obturator system recedes and the profunda femoris penetrates. So there's a transition that is happening over this age group. Now, because of some unknown reason, some unknown idiopathic reason, in some people, a brief period comes when the transition has been affected, it's not smooth. And so for that brief time, a part of the femoral head loses the blood supply and undergoes VVN. So that age is what is pointing to you. It's a painless limp. And you can very well see in the whole scenario, there is no injury, no trauma. So that's why, I've talked of a painless limp in Perthes. So are you guys clear with the problem in Perthes? Are you guys clear with the problem in Perthes? Perhaps I know you are very much familiar with the treatment also in Perthes. We generally give bed rest to the person. Very difficult to give bed rest to a child. We generally put him on skin traction to ensure that he rests. So I hope you got my message why we are just depending upon bed rest. Because it is body only that can normalize this transition. So we just have to ensure that till this transition is not happening, the patient is not bearing weight so that a head does not collapse. The patient will keep bearing weight, the head will collapse and it will become a flattened head, and this flat head in Perthes has been compared to a mushroom, and that's perhaps what you see in Perthes as the classical most sign, a fat head that's called as a mushroom shaped head. Another thing you might find is a gauge sign, which is a triangle shaped lytic area that you may find in the lateral femoral neck, like you see over here. I've marked it very clearly. Or another thing that you may find is a sagging rope sign. So here what you have is a whitish line in the medial femoral neck. So I hope you can very well see that white line in the medial femoral neck also. So these are particularly the X-ray signs that tell you that this is likely a case of Perthes disease. So are you guys clear with that understanding of Perthes disease? समझ में आ गई है? Navneesh, Shitish, Bindu, DK, Jitin, Adnan, you understood what exactly is happening in Perthes, perhaps how we decide the treatment in Perthes. You're clear with these X-ray signs that tell you this is Perthes, and gauge sign is one of that sign that's specifically associated with a poor prognosis in Perthes. An extra point. Clear? So that's how I've taken the answer here as Perthes, considering the age group and the fact that it's a painless limp. It could have been possible that even congenital dislocation of hip could present in this way, but generally congenital dislocation of hip patient will present earlier. So what is basically happening in congenital dislocation of hip? You have a developmental dysplasia of hip. Dysplasia means abnormal hip. So what you have over here is a flat acetabulum. So see this affected side. See this acetabulum so flat. Look at this normal acetabulum so curved. So this is the prime problem. Because of some unknown reason, these people have a flat acetabulum. Now since the acetabulum is flat, the head dislocates without any injury. So no injury, so painless condition. Clear with that? Now as this head will dislocate, the ossification of the head is going to be delayed. See, this is a child who's just born. So the dominant system is going to be this ligamentum teres, obturator system. So if the head will dislocate, this dominant vascularity pattern here would be gone. So obviously the ossification is going to be delayed. Now because of this delayed ossification, what you're going to find with the femoral head? Small in size. Like if you see here, this is a big head, this is a small head. So the head is also dysplastic, abnormal. So that is the whole story in developmental dysplasia of the hip. So you will have a person who will be having a flat acetabulum, a head that is small in size. Perhaps this is the whole story. The problem starts with that flat acetabulum leading to the head dislocation without any injury, painless dislocation. Dislocation leads to a delayed ossification of the head, causing a head that is small in size. So the hip dislocates without an injury, like you see over here. This small head, this flat acetabulum, shouts to you the diagnosis in case of congenital dislocation of the hip. But yes, these people would generally come to you a little earlier. Okay, but in Perthes, you will find that classical age pattern only. But here you could have presentations across all ages. So that is why congenital dislocation of the hip had kept a little low. And yes, when I've talked of congenital dislocation of hip, no way can I proceed without telling you the treatment in congenital dislocation of the hip. See, in first 6 months, all we advise to these people are the abduction splints. So what you are seeing in this first image is a von Rosen splint, and what you are looking at in the lower image is a very popular splint that's called a Pavlik harness. This picture was there in the previous INI-CET paper, so please have a good look. The idea behind these splints is to keep the hips, you can see here, we are trying to keep the hips in abduction. See, how is abduction going to help? Abduction is going to lead to containment of head. And mind you, what has been seen in DTH, that containment is what leads to a normal development. See, if I am going to abduct this femur, the head is going to drop into the acetabulum. So what has been seen in DTH, that if by using these abduction splints for a period of 3 to 6 months, you are able to contain the head within the acetabulum, the development is normal. The problem automatically corrects. So that containment is the key. And first 6 months, all you need for containment are these abduction splints. In case this age of 6 months is gone, almost up to the age of 3 years, you have to go with a closed reduction or open reduction, followed by an abduction plaster. Now when a head is dislocated for more than 6 months, fibrous tissue will generally fill up the acetabulum. So simple abduction may not be able to reduce the head because of that fibrous tissue in the acetabulum. So now you have to take this patient to the OT. And then you can, under anesthesia try a closed reduction or open up and reduce the head and then apply the abduction plaster. But here also, the idea is containment of the head so that there can be normal development. So I hope you are clear with the treatment in this zone. The problem comes when this age of 3 years is gone, because this is the age after which the development potential of the hip is gone. So now the head cannot remodel, now the acetabulum can no longer become a curved structure. So this is the age where the surgeon generally starts opting for acetabular osteotomies. So now you have to cut the acetabulum and artificially make it a curved structure, because now by development acetabulum cannot become by itself a curved structure. So are you guys clear? Clear? Okay. So DK, how to differentiate Pavlik harness from a von Rosen splint? I'll tell you. Pavlik harness is a dynamic splint. So please, what is meant by dynamic? In a dynamic splint, movement is possible, and movement leads to more of correction. Now if you will see Pavlik harness, you can see the straps going till the foot. The theory here is, as this child kicks, the feet are such connected to the hips that every kick generates more of abduction, because it's a dynamic split. And that's why more preferred out of the two, Pavlik harness. And that's why you had the picture of Pavlik harness in your exam, not the von Rosen splint, because practically we'll have to go with the Pavlik harness. Von Rosen is static splint ending at the level of the hips, but Pavlik harness going till the level of the feet. So clear, Dr. Pihu, you were absolutely right, but I hope you're now clear why you have those foot attachments in public harness. And DK, are you clear with your query also? So please have a good look at these pictures and please go through the treatment of congenital dislocation of the hip. I hope you're clear with the mechanics behind the treatment also. So I hope you're clear with everything till here. Now a very popular picture again in front of you. A picture that has again been a part of the INI-CET paper. ये पिक्चर भी आ चुकी है. Well, thank you for the lovely comment of Pihu. But time for you to answer now. Can you identify this particular splint for me now? Again, this picture has been there in one of the INI-CET papers. So can you guys help me to identify what is being shown in front of you? ये क्या है? Yes, please. What do you think is the splint that's shown in front of you? Very popular splint. Yes, absolutely right. So you have these two shoes. They're mounted on an iron rod. So you're absolutely right. So that's what you call as a Dennis Brown splint. Yes, so that's a Dennis Brown splint. Absolutely right. But guys, in case I've prescribed a Dennis Brown splint, what is the problem I'm dealing with? Yes, Jitin, you're absolutely right. I'm dealing with a case of CTV. Yes, CTV. Congenital talipes equinus varus. So that's what CTV is. So please, CTV is not a disease. It's a group of deformities in the foot. So when you see the heel in these people, you will find the heel in the air. Because this anchor joint between tibia and talus, that tends to be in plantar flexion. And this plantar flexion that you see at the ankle, in orthopedics we call this as equinus. So that is the first deformity in CTV you find. Now I hope you can very well see this heel is twisted medially. I'll tell you why. Because what you have at the heel is varus. So please, this talus sits on top of calcaneum. So this is the subtalar joint. Subtalar joint is the joint that gives you those movements of inversion and eversion. And inversion, eversion are anatomy terms. Orthopedics में same चीज को हम कहते हैं varus and valgus. So the subtalar joint goes into varus, inversion. That's what's varus in orthopedics. Now I hope you can pick up this medial longitudinal arch, quite exaggerated. This is what we call as cavus in orthopedics. So medial longitudinal arch in these people will be exaggerated. And if you will see these metatarsals, you will find them to be adducted. Adducted means pointing medially. तो metatarsals भी medially point कर रही हैं. I hope you can pick up these metatarsals. They are adducted means they are pointing medially. Clear with that? तो जब हम किसी के पैर की तरफ देखते हैं, हमें हील हवा में मिलती है, means equinus is there. हमें हील मीडियली ट्विस्टेड मिलती है, मतलब वेरस इज देयर. हमें मीडियल लॉन्गिट्यूडनल आर्च एक्सैजरेटेड मिलती है, मतलब केवस है. और मेटाटार्सल्स मीडियली पॉइंट करती दिखती हैं, मतलब एडक्शन है. दैट इज वेयर वी कीप दैट स्पॉट डायग्नोसिस. दिस इज सीटीवी. द बेसिक प्रॉब्लम इन सीटीवी ऑन द पोस्टीरियर medial side of the foot, these soft tissues are contracted and these contracted tissues are pulling the foot medially. That is the basic problem in CTV. If you understand the basic problem in CTV, it's very easy to understand the treatment. In first 1 year of life, you go with serial plasters, means a plaster every week to stretch these tight soft tissues. This particular mode of treatment is popularly called as Ponseti casting. So that's what you do in the first 1 year of age. Some books have given that at birth you go with some manipulation by mother. Please don't use it. All the standard literature in orthopedics says right from day one you can start with Ponseti casting, but not in every child you will find the skin condition to be pliable for casting. in those cases you can wait for 4, 5, 6 or 7 days. For that time you can just keep the child under observation. But as early as 1 week you can start with Ponseti casting safely. In case the age is gone between the age of 1 to 5 years. Now this is where just stretching the soft tissues might not correct the deformity by plasters. Now you have to take up the patient for surgery. So you have to cut those tight structures, tight soft tissues on the posterior middle side of the foot. And that's what we call as posterior medial soft tissue release. So this is where the surgical intervention starts after the age of 1 year in CTV. Now, if this age of 5 years is also gone between the age of 5 to 12 years, here you have to go with bony procedures, bony osteotomies to correct this deformity. In this age 5 to 8 years, most of the doctors love to go with an osteotomy that's called as Dillwyn-Evans procedure. And in this age of 8 to 12 years, the doctors generally love to go with a procedure called wedge tarsectomy. So these are the options that are chosen between the age of 5 to 12 years. And yes, if this age of 12 years is gone, deformity becomes so rigid that now in order to correct that deformity, we have to go with just this procedure that we are left with, that triple arthrodesis. So are you guys clear with the treatment of CTV across all ages? And yes, posterior medial soft tissue release, this is called Turco's procedure, okay, because Turco described it. And Dillwyn-Evans procedure is separate, that is done in a different age group. It's a bony procedure, not a soft tissue procedure. So clear, Jitin, with that also? Jitin, Dwyer's osteotomy is not meant for a case of CTV. You correct CTV by any of these methods, you have to maintain the correction for at least a period of 2 years or maybe 3 years. Actually, till the child is 5-6 years of age, so that foot musculature develops and musculature can control the foot. So for maintenance you use these Dennis Brown splints. But many people, many children don't use these splints. They're not compatible with these splints. They don't take this treatment nicely, so reoccurrences happen. Now if a reoccurrence happens, sometimes only one deformity comes up. Like isolated heel varus might come up, other deformities might not come up in reoccurrence. So when you have that reoccurrence and only heel varus comes up, that is where you can go with Dwyer's osteotomy. So clear with that, Jitin, when to do Dwyer's and when to do Dillwyn-Evans and when to do Turco's soft tissue release? So don't confuse the three things. The three procedures are absolutely different for absolutely different scenarios. And Jaipur foot is for an amputation case. It's an orthosis, a splint. Jaipur footwear is not for this case, Adnan. So Jitin, Adnan, clear with your queries? Clear with your queries? Yes. So please give me the thumbs up so that I can move ahead and discuss some more important topics. Okay, because this treatment has been always a confusion for the students, because the books don't give them in a very clear way. So I hope I've clarified each and everything to you in an effective way from authentic references, mind you, please. Okay, so please follow what I've told you in a fearless way. Okay, so if you have to screen school children for scoliosis, what should you do then? What should you ask them to? Ask them to bend backwards, forwards, lift the leg or stand on one leg. So what will be the way for it? How to screen school children for scoliosis, please? Please, how to screen school children for scoliosis? So please help me out with this one. B, yes. Ask to bend forwards. Yes, in fact, this is a designated clinical test that's called Adams test. So guys, please, scoliosis. First of all, I think you guys are pretty much clear as to what is scoliosis. Where you have a lateral deviation of spine that's more than 10 degrees. Okay. Now this scoliosis can broadly be classified into a structural deformity or a postural deformity. In postural deformity, as a child bends forwards, curve disappears. And that is what is Adam's test. As you bend forwards, curve disappears in postural scoliosis. Okay, so that is Adam's test. And mind you, structural scoliosis, you bend forward, a rib hump appears at the back, so the curve becomes more prominent. So that is why this bending forward, that Adam's test, is so useful to decide whether you're dealing with a case of postural or structural scoliosis, because intervention is only required for structural scoliosis. And structural scoliosis is basically a developmental deformity of the spine. With development, the spine has become, curved like this. That is what is happening in scoliosis. Now, if it is postural scoliosis, you will straight away channel the child to a physiotherapist for a good postural control. But structural scoliosis first needs to be graded for the severity. And for this, you use that Cobb's angle. What's Cobb's angle? First, identify the curve. Now, draw a line along the topmost vertebra. Draw a line along the lowermost vertebra of the curve. So when you join the upper and lowermost curve vertebrae, this is what you call as Cobb's angle. In fact, even the definition of scoliosis is based upon Cobb's angle. So when you find that Cobb's angle to be more than 10 degree, only then can you put the tag of scoliosis. Clear with that? That lateral deviation I'm talking of this Cobb's angle. So it's Cobb's angle that tells you about the severity. See, higher the angle, severe the disease. So this is the simple formula that is followed for scoliosis. Now, a very important thing in a scoliotic curve, it's a developmental deformity. So as you will develop, the deformity will progress. So every doctor wants to know regarding the risk of progression. To predict the risk of progression, we go with what we call as a riser's grading. So please, this is the iliac apophysis. This fuses with ilium as you grow. How much of this iliac apophysis has fused with the ilium tells you the riser's grade. Like grade 5, this complete fusion of the iliac apophysis. Grade 1, minimal fusion. So कितना पार्ट iliac apophysis का फ्यूज कर चुका है tells you the riser's grade. But mind you, if there is complete fusion, there is no growth pending in the body. And if there is no growth pending in the body, there is going to be no progression in scoliosis, because scoliosis being a developmental deformity, growth के साथ it increases. So in a simple way, Cobb's angle is high, it's a severe disease. But riser's grade is more. There is no chances it will progress at least. So low riser's grade is a problem, not high. In fact, this is how we decide the treatment in scoliosis. See, in scoliosis, I just check up the two things in my patient. What is the Cobb's angle? And what is the riser's grade? Now when I find the Cobb's angle is more than 45 degree, means it is high. And when I find the riser's grade is low, say 1 or 2 types, so this tells me it's a severe disease, and this tells me the chances of progression are very high. So this is where I opt for surgery, which is spinal fusion. I fuse the spine so that the deformity does not progress. If this scenario is not there, I opt for braces. And I must tell you the two most popular braces we are using in scoliosis. What is shown over here is a very popular brace called Boston's brace. What is shown over here is again a very popular brace called Milwaukee's brace. Last year, INI-CET paper, this picture was there. Milwaukee brace is a very bulky brace and it gives you the best correction. Boston's brace gives you a reasonable correction, but it is very comfortable brace. So most commonly used brace tends to be the Boston brace. So are you guys clear even with the brace bearing scoliosis? Okay. So the Pihu 70 degrees is very severe angle. Generally anything above 45 degrees taken as severe angle. 70 degree means straight away take up for spinal fusion. So are you guys clear even with the treatment principles in scoliosis? You've understood everything about scoliosis. You've understood the logic behind Adam's test. Yes, Bindu, Adnan, Jitin, Piyu, Navneet, Shruti, Raj, are you guys clear with all fundas on scoliosis? Because this has been one of very popular topics with the examiners over the last couple of years, at least for the AIMS and INI-CET papers. Perfect enough, perfect enough. Fairly easy one. 20 years male not responding to NSAIDs since 3 weeks. There's a lesion over here. Quickly tell me. I think even looking at this X-ray, you will have the diagnosis. There's a lytic lesion in this proximal tibia. So what is the likely diagnosis? Braces will halt the progress. So Pihu, the idea is to halt the progress. The deformity does not become severe. The patient will remain symptomless. Clear? Okay, so yes, I give it to you guys. This is a case of Brodie's abscess. See, a ring sequestrum you have in cases of chronic osteomyelitis. Sequestrum is a part of chronic osteomyelitis. In chronic osteomyelitis, the duration of symptoms is more than 1 month. In acute osteomyelitis, the duration of symptoms is less than 2 weeks. So it is Brodie's abscess that comes under the category subacute osteomyelitis, where the duration of symptoms is between 2 to 3 weeks. So this 3 weeks symptoms tells you it is Brodie's abscess. In Brodie's abscess, even the commonest site that tends to be proximal tibia. So this is again the commonest site for Brodie's abscess. And guys, osteoblastoma is totally out. It is a diaphyseal lesion. Please, infections are metaphyseal lesions. So this is a metaphyseal lesion. So osteoblastoma is out because this is not a diaphyseal lesion. तो इसलिए मैंने osteoblastoma पहले out कर दिया. But anything else also that tells me that this is not osteoblastoma? Yes. Anything from the history that tells you that this is not osteoblastoma? Yes, yes, yes. So please, anything else in this whole history that tells you that please don't take osteoblastoma? It will be a crime here. NSAIDs, absolutely right. So what you find with osteoblastoma, a diagnostic response to NSAIDs, and here this patient is not responding to NSAIDs. Perhaps how can he respond to NSAIDs? This is infection. Infection will need antibiotics, not NSAIDs. Osteoblastoma might respond to NSAIDs. So that's why I've totally taken out osteoblastoma, and this is a case of Brodie's abscess. Full marks, full marks, full marks. Now this is a picture that has been doing the rounds in so many exams. Okay, I think looking at this picture, you can tell me what appearance is this and what is the diagnosis. Like, it's a spot diagnosis. So 35 years old male who's come to you with this picture. So what is the answer here? Yes, this is GCT. So age is helping you out, and soap bubble appearance is helping you out. Okay, so that's what's telling you this is GCT. Okay. Well, whenever an X-ray comes and you are asked about a tumor, which is a very common scenario, you would have won half the game. If this slide that I'm now going to give you will be a snapshot in your mind. See, it's very difficult for an examiner to hide the age of the patient. At least even if it does not give the age, you can see there are no growth plates. No growth plates, so it's an adult. So indirect idea भी age का लग जाता है looking at the bone. Okay. So one thing is age will help you out. Most of the tumors you will find in the growing age, somewhere between 10 to 25 years. There are very few tumors that bar this age. If you talk about 40 to 60 years age group, remember chondrosarcoma in this age group, hemangioma in this age group. Okay. A middle type of an age, say 20, 30, 40 years age, This is where you classically find GCT, giant cell tumor, middle age, 20, 30, 40. So look at this age, 34 years, GCT. Clear? Now there is one tumor in orthopedics that's popular for a bimodal age distribution, means young as well as old. And this tumor tends to be osteosarcoma. Young में भी मिलता है, old में भी मिलता है. Clear? So half of the information in any such case will come from the age. The other half will come from the part of the bone that is involved by the tumor. Mostly you will find tumors concentrated on the metaphysis, because in the metaphyseal area of the bone you have the physis, what you know as the growth plate. So growth plate metaphysis में होती है. Tumor is all about growth. So maximum tumors इस एज में मिलते हैं, physis में मिलते हैं, metaphysis में. जैसे maximum tumors इस एज में मिलते हैं क्योंकि इस एज में वो puberty होती है, maximum growth होती है. So tumor is all about growth. Now the tumors that will not be in the metaphysis, either they will be the tumors of the epiphysis or they will be tumors of the diaphysis. अब epiphysis में GCT मिलता है और chondroblastoma मिलता है. The mnemonic is ECG. ECG, epiphyseal tumors, GCT and chondroblastoma. ECG. So these are the epiphyseal tumors. तो epiphysis में ये मिलेंगे. डायाफाइसिस में एक तो ऑस्टियोब्लास्टोमा और इसी का वेरिएंट होता है ऑस्टियोट ऑस्टियोमा, डायाफाइशियल ट्यूमर, जो भी हम पढ़ के हटे हैं. और डायाफाइसिस में दूसरा ट्यूमर याद रखना है ईविंग सार्कोमा. If this information is there in your mind as a snapshot, half of the questions on tumors will be self sorted. मतलब शुरू करने से पहले अपने आप खत्म हो जाएंगे. I'll give you an example. 15 years old boy has come to you with a complaint over his left shoulder. The X-ray says this is an osteolytic lesion in the epiphyseal area of the proximal humerus and there is stipple calcification. Surgeon has recommended a biopsy of the lesion. The pathology says biopsy में fibrous matrix and some giant cells. So most likely diagnosis in this particular case. So please submit your answers so that I know you have understood everything. जल्दी से answers submit कर दो. So please submit me your answers here. Yes guys, please. Okay, Jitin says chondroblastoma. Kshitij says fibrous dysplasia. Yes, may I have some more people submitting answers? Some more people submitting answers? Yes. So please submit your choices and then I'll tell you what is the correct answer in a logical way. Yes. A. Adnan says giant cell tumor. Perhaps because he can read here giant cells. So Adnan, I told you yesterday also, orthopedic surgeons smarter than they look. So guys, just use this slide on this question. आधी options गायब हो जाएंगी. See, fibrous dysplasia chondromixoid fibroma. There will be metaphyseal tumors. ना ये epiphysis वाली लिस्ट में है, ना ये diaphysis वाली लिस्ट में है, दोनों. Clear with that? So ये वाले tumors तो metaphysis वाले, and it's clearly written lesion is an epiphyseal lesion. So they are out. Now these are epiphyseal tumors, ECG, mnemonic. Remember the mnemonic for epiphyseal tumors, ECG. So they both remain in the game. Now, if it was a case of GCT, it had to be that age 20 to 40 years. But look at this age, 15 years. So the age is pointing to me, this is chondroblastoma. Getting it? So that's why I've chosen it as an answer. So आधी चीजें यहीं से solve हो जाती हैं. But yes, other things that can help you out also. Now in chondroblastoma, calcification will be classical. Calcification is basically a feature of cartilaginous tumors. जब भी कभी कार्टिलेजिनस ट्यूमर की बात होगी, कैल्सिफिकेशन की बात करनी है, chondroblastoma, chondrosarcoma, that's enough. GCT is not a cartilaginous tumor, so there will be no calcification that will be seen in GCT. It is clearly written stippled calcification. So I'm most staunch that this is chondroblastoma. See, chondroblastoma. This is what you see on the X-ray. That the examiner was mentioning to you stippled calcification. And cartilage tumor, calcification. Characteristic. Calcification means it's a cartilaginous tumor. Clear? And yes, in chondroblastoma, even on the biopsy you see this calcification, but ये जो biopsy पे तुम calcification देख रहे हो, this is called a chicken wire calcification. So Shruti, it's not called a picket fence calcification, it's exactly called a chicken wire calcification. A picket fence appearance is different. You haven't the proximal femur in hyperparathyroidism. I'll talk about it sometimes else. But this is chicken wire calcification as Jitin has mentioned to you. Clear with that? So these calcifications can simply point to you that this is chondroblastoma. I know some people had answered it at GCT because they were carried away by this fact that on biopsy you have giant cells. But please do not forget that even chondroblastoma can have giant cells on the biopsy because this tumor is a giant cell variant. I think you are clear as to what is a giant cell variant. See, in biopsy of giant cell tumor you have giant cells like you see here, but it's not only GCT that can have giant cells on the biopsy. There are some other tumors also that can have giant cells on the biopsy. So जिस tumor की biopsy पे giant cells मिल सकते हैं, aneurysmal bone cyst, simple bone cyst, fibrous dysplasia. So even in fibrous dysplasia you can have giant cells on the biopsy, and perhaps I think that is why in this particular question the examiner he had kept fibrous dysplasia as one of the option because this is also a giant cell variant. Then there is a variant of fibrous dysplasia that is called non-ossifying fibroma. Here also you can have giant cells on the biopsy. Then chondroblastoma, very popular giant cell variant. And then there is a variant of osteosarcoma also that is called osteosarcoma with giant cells. So please do remember the list of giant cell variants. And absolutely right, Brown's tumor, you can also find giant cells on the biopsy. But please, the word tumor is a misnomer. Dear Adnan, Brown's tumor is in hyperparathyroidism, not tumor. It's called a tumor. So right now I'm giving you the tumors that are giant cell variants. So that's why it's not included Brown's tumor. But certainly, even in Brown's tumor, you can have giant cells on the biopsy. Clear with that. So giant cell variants में chondroblastoma भी आता है. So you can have giant cells on chondroblastoma. So that's why I picked up the answer as chondroblastoma. But trust me, you read calcification means it's a cartilaginous tumor. सोचे समझे बिना cartilaginous tumor pick कर लो. Clear with that. And please don't confuse calcifications with periosteal reactions. इन दोनों को आपस में confuse मत करना. See, periosteal reaction is a new bone formation. Now these new bone formations are particularly popular in two tumors, Ewing sarcoma, osteosarcoma. In osteosarcoma, this new bone formation takes the shape of a triangle or the sun rays, and you are familiar already with these signs: Codman's triangle, sun ray appearance. So these are not calcifications, these are periosteal reactions. And in Ewing sarcoma, you are all very familiar with this periosteal reaction that you call as the onion peel appearance. But let me explain to you what is onion peel appearance. Look at this bone. See, this bone is all gone. But can you see the absent bone is replaced by this huge bone formation? Now, if you take this bone in your hand and you cut it, you will find that this bone is having layers of periosteal reaction, lamellated periosteal reaction. That is onion peel appearance. So, are you guys clear with what is calcification, what is periosteal reaction, where to speak of calcification, where to speak of periosteal reaction? Periosteal reactions you have in malignant tumors that are bone forming, like Ewing sarcoma, osteosarcoma. So clear with that, guys? Can I have that thumbs up if you guys are clear with everything till here? यहाँ तक चीज़ें समझ में आ रही हैं? Can I have that thumbs up? Yes. Kshitij, Shruti, Ihu, Adnan, Jitin, Raj, all comfortable with me till here? Okay, Navneet, wonderful, 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 wonderful. Spot diagnosis. Look at this image. Tell me the spot diagnosis. So look at this image. Tell me the spot diagnosis. Yes. Yes. Oh no. I've asked where you are not going to see this. See, this is that very popular Shepherd crook deformity in the proximal femur. Fibrous dysplasia will be the classical cause. So this is the you will have this in fibrous dysplasia. You can have it in osteogenesis imperfecta. You can have it even in Paget's disease. Gaucher's disease is the answer here. तो Gaucher's disease में ये नहीं मिलती. Gaucher's disease, come on. You find this deformity, flask-shaped distal femur, Erlenmeyer flask deformity. I hope now you can recall. शायद गलती से भूल गए थे. Or I think you were just carried away that if this deformity is there, what is the diagnosis of fibrous dysplasia? तो शायद उस तरह carry away हो गए थे. But yeah, the question you did not read. It is like where you don't find it, Gaucher's disease, because what you find in Gaucher's is Erlenmeyer flask deformity. So just a small mnemonic to share with you, a doctor girlfriend, that you should never have if you want peace in life. DOCTORGF. So that's how you know you can remember the causes of except not seen, but perhaps I think you're clear with the formula, Jitin. So please do note down this formula. This will tell you all the causes behind an Erlenmeyer flask deformity also, and you are already clear with the causes behind Shepherd crook deformity. तो Shepherd crook deformity के causes clear हो गए हैं. Erlenmeyer flask के भी याद रखना. Piles disease, dysplasia of metaphysis, osteopetrosis, achondroplasia, thalassemia, Olius disease, rickets and RA both can give you Erlenmeyer flask deformity. Gaucher's disease can also give you Erlenmeyer flask deformity. Okay. And fibrous dysplasia can also give you Erlenmeyer flask deformity. So I hope you are clear with the causes of this also. Look at this image and tell me the X-ray sign and what disease am I talking of. This is again a spot diagnosis. So there's a cavity here. This is a cavity in the metaphysis of proximal humerus. A piece of cortex has broken and fallen into the cavity. So what is the diagnosis? And what is this X-ray sign called as? Please tell me. Now this is again a spot diagnosis. You look at this image, you will have the diagnosis. No, not ABC. You were close, Shilpi. A simple bone cyst. A simple bone cyst. And what you can see over here is that very popular fallen leaf sign. So guys, simple bone cyst does not have septa. So piece of cortex often falls into the cavity. In aneurysmal bone cyst, there are multiple septa. So this piece does not fall down. It is unable to fall down because of septa. So clear with your mistake, Shilpi. This is simple bone cyst. So if you see the fallen fragment, it tells you this is likely a simple bone cyst and not an aneurysmal bone cyst. Clear? Clear. This is an X-ray. This is an X-ray. This is an X-ray. This is an X-ray. Okay, one last one, and then the class will be over. One last one. Vertebral bodies are biconcave, like a codfish spine. So what is the likely diagnosis? SB seen in metaphysis, Navneet. See, this area is epiphysis. This is epiphysis here. Epiphysis is paired. So can you see this cavity here? This is the cavity. So I hope you can very well pick up. It's a metaphyseal lesion. SBC you have in the metaphysis. I've just given you the formula. So clear, Navneet, with your query? Okay. So codfish spine biconcave vertebra. B and D. Not hyperparathyroidism. No. Osteomalacia. Classical. Codfish spine. Classical of osteomalacia. I'll just show you the spine deformities also. See. If you see these picture frame type of vertebra like this, where the edges are white, it's like a picture frame of a picture. Or if you see totally white vertebra, ivory vertebra, these are the scenarios where the first thing that should come to your mind should be a Paget's disease. Clear? If you see rugger jersey spine, white, black, white, black, white, black, white, black means alternate white black areas, like a jersey. First thing that should come to your mind should be hyperparathyroidism or renal osteodystrophy, that is also hyperparathyroidism only, or marble bone disease, what you know as osteopetrosis. So that is where you find rugger jersey spines. Now if you have these vertebral margins, collapsing and opposite margins forming this picture like a fish mouth, that is what is called fish vertebra. Some people call these opposing vertebral margins as codfish mouth. Some people say that these double margins you see, they are resembling the codfish vertebra, the mouth of the vertebra, fish mouth vertebra, codfish vertebra, same. So when this is the scenario, osteoporosis should be the first thing, or even in osteomalacia, you can see these codfish vertebrae. So are you guys clear with the causes you have to keep in mind if you see this special type of vertebrae? Picture frame vertebra, whitish vertebra, Paget's. Rugger jersey spine, osteopetrosis or hyperparathyroidism. These fish mouth type of vertebrae, osteoporosis, osteomalacia. Clear with that? Paget's में ivory vertebra, picture frame vertebra. और हाँ, Paget's disease की बात करें तो Paget's disease में होता क्या है? An abnormal bone turnover. So I'll tell you, first of all, there is a very high bone resorption going on because of some unknown reason. But this is coupled with a same high rate of bone formation. So basically you're all familiar with this fact that this is the osteoblast and this is the osteoclast. The parathyroid hormone attaches to its receptor on osteoblast, and then by virtue of a protein called rankle, a blast goes and activates a clast, and it is clast that leads to bone resorption. I think everyone is clear with this cycle. You can very well understand कि अगर PTH ने बोन रिजॉर्प्शन करनी है तो बोन फॉर्मेशन ऑटोमेटिकली बढ़नी है, क्योंकि PTH डायरेक्टली क्लास को एक्टिवेट कर ही नहीं सकता. So that high resorption is happening because of some unknown reason that will be coupled by high rate of bone formation also. So that is why in Paget's you are having that high bone turnover. Now when it is resorption that is predominating, there is a lytic stage where bones are blackish. When bone formation is predominating, there is a blastic stage where you find whitish bones. So that is what is happening in Paget's. black white type of bones. कभी lysis ज़्यादा है, कभी sclerosis यानी blastic stage ज़्यादा है. So these stages give you these classical X-ray signs, that picture frame vertebra, this whitish heliopectineal line, what you call as a brim sign, or this spot. I think you know that term, cotton wool spot. This osteoporotic patch on the skull, lytic patch on the skull, or sometimes this bone resorption proceeds in the form of this V shape. This V-shaped bone resorption is what you call as a blade of grass appearance. So these are the X-ray signs that tell you are dealing with likely a case of Paget's disease. Why I've covered up so much of images? Because in my experience last year, most of the exam in orthopedics was images. So clear with those classical signs of Paget's disease? ये भी समझ में आ गए? So clear with everything? Can I have that final thumbs up? You clear with everything? Yeah, blade of grass sign. So bone resorption होती है lytic stage में, वो progress करती है ऐसे V की shape में. This is called blade of grass appearance, V-shaped. Clear? So clear with those X-ray signs? Lytic stage में ये osteoporotic patch मिलेगा, cotton wool spot. Sclerotic stage में, plastic stage में ये sclerotic brim sign मिलेगा. Sclerotic stage में ये picture frame vertebra मिलेगा, जो eventually जाके ivory vertebra बन जाएगा. So picture frame vertebra will only progress to become ivory vertebra in the plastic stage in Paget's. So clear even with the X-ray signs of Paget's? Perfect enough. So that's all from my side for today. Wish to attend more classes. Please subscribe to Unacademy. uh, there's a 25% offer going on. You can just check out the website for the details and avail this offer. Heavy discounts, and you subscribe, you can be part of those learners who successfully uh, scored well in the NEET PG exam. And yes, in case you don't want to subscribe, still you can take some advantage. You can watch the quality educators we have with us, preparing you for the upcoming INI-CET exam through this IPL, the INI-CET Premier League. So this is the schedule for various classes. Orthopedics part is over. I took a class yesterday and a class today. And in case you just subscribe, you will be touch with the best educators of the country. You're preparing for FMG, there's a batch going on for you. You're preparing for this next or NEET PG upcoming, there's a batch going for you. So choose your batch, and in case you're subscribing, you can use my code also if you want, OrthoLife, to get your 5% off. And otherwise there are some other offers also. You check up the website for availing a better discount. Okay, so Adnan, you want to help me out to tell you the difference between a Jones and a pseudo Jones fracture. So in Jones fracture, you have a fracture involving the base of the fifth metatarsal, and this will be the metaphysio-diaphyseal junction area involved. But when you talk of the pseudo Jones fracture, it will be the tip of the fifth metatarsal that will be fractured. So suppose this is the fifth metatarsal. If this is the metaphysis, this will be the diaphyseal area, this will be the metaphyseal area. So if you have a fracture the metaphysio-diaphyseal junction, this will be Jones. But if this tip fractures, this is where you will call the fracture as pseudo Jones. So clear with your query also, Adnan? Clear with your query also, Adnan? So people comfortable with everything till here? Okay. Any doubts are there once this class is over? This is a Telegram group with which you can connect yourself with, t.me, Dr. Mukul Ortho, and you can ask me your queries on this group also. So you can stay connected with me, and I'll try helping you out as much as I can as you're preparing for this upcoming very important INI-CET paper. So wish you all the best, guys. And in the end, a small message. The exam is about to approach. Don't run after reading extra. Revise all that you have already read before you go. Some very good lectures are there on Unacademy. Make sure to watch them up. Watch the high yield material and stress on reading the high yield material, not conceptual books. Practice more of the MCQs. Fine. So thank you for the lovely comments. Good night for today. Wish you guys all the best. Bye bye.